Time for the sixth nerve. So I invite Dr. Vivek Warkad for his presentation on management of sixth nerve, a case-based approach.
Yes, so I would like to thank the scientific committee for giving me this opportunity. So basically, I'll talk about how to manage the sixth cranial nerve palsy, and I'll present a couple of interesting cases. I do not have any financial disclosure. So what do we need to do when we come across a patient with sixth nerve palsy? So we need to watch for spontaneous resolution. I think this is very, very important thing that we need to understand in our day-to-day practice for at least 6 to 9 months, especially in traumatic sixth nerve palsies. Assessment of residual rectus muscle function by performing FDT, and also the force duction test to identify the extraocular muscle contracture, that too on table. So having understood this basic concept, when you want to deal whether in a surgical or the non-surgical methods of treatment of sixth nerve, the most important initial strategy is monoocular occlusion to avoid the double vision, prisms, and also the botulinum toxin injection. So we have these three things in our armamentarium to tackle the early phase of any sixth nerve palsy. So the prisms, there are two types, slab of prism and the Fresnel prism. However, most of the time you can tide over the acute response of the patient to the diplopia, but the most of the patients they are not very happy. They want the permanent solution. So over a period of time you can subject them to, like in early phase the Botox injection, but again there are pros and cons of using Botox, understanding the natural recovery of these patients with sixth nerve palsy. So what options that we have as a surgical treatment? If we have a partial sixth nerve, as we have wait and watch, and then probably we do have recession depending upon how much is the primary angle of deviation and how much is the abduction limitation. We can have medial rectus recession, lateral rectus resection, R&R, and also the R&R along with, if the primary deviation is beyond the range of unilateral R&R, you can always touch to the other eye medial rectus. If there is a total sixth nerve palsy, then we have the n number of surgical options, from traditionally to what latest we are trying to do, and that has been over a period of decade a standard of care. So we have different surgical procedures, as you can appreciate. The most commonly used in today's world is Nishida's procedure, and the superior rectus transposition with posture suture augmentation with and without medial rectus recession. So that's a SRT, with and without medial rectus recession. So if you look at the literature, I think they are very much well established surgical procedure. From our own country, I think Dr. Pradeep Sharma and Dr. Rohit Saxena, they have published extensively on the Nishidas and the modification Nishidas with adjustable suture for the sixth nerve palsy. If you look at the SRT, I think this is the first one bought by Mendalia and group from Harvard. They transposed superior rectus to LR. So basically, we are trying to direct the vector of the superior rectus to the lateral rectus, and that's how it helps to improve the abduction, which got the paralyzed because of the lateral rectus palsy. So we have our own the experience where it works amazing, the SRT, and we have seen that this has also been utilized in patients treating with not only the sixth nerve palsy, but the type 1 Duane's retraction syndrome along with medial rectus recession. So let's move on to the case. So this lady, you need to understand, the primary evaluation is always look for systemic risk factors. So this particular patient, if you see that she has a very gross motility limitation with very large primary angle deviation. So on evaluation, she turns out to be, the ischemic sixth nerve. So here you need to treat the cause. So control all the systemic risk factors and keep wait and watch strategy. You will find that, these patients will improve very dramatically. So you can appreciate that she's almost straight in a primary gaze with complete motility recovery. And what is this case teaches that treatment includes strict control of ischemic risk factors, Nowadays, as in this patient, we found that, homocysteine, which is known to be, an independent risk factor. We have an in-house publication by Dr. Virender how homocysteine alone can cause, sixth nerve palsy, and when you treat it, there will be a complete recovery of sixth nerve. So that we need to keep in mind to add this particular investigation as a part of, the systemic evaluation. Monoocular occlusion is the best way to get rid of diplopia in ischemic sixth nerve palsy, considering, the rapid rate of resolution of ischemic palsies most of the time. This is another case, a child presented with a trauma. So again, this is a kind of, the traumatic sixth nerve palsy with a gross abduction limitation. There was elevation limitation for obvious reason because of, the orbital inflammatory component. This child has a very large esotropia with -4 abduction limitation. Again, what we understand that the strategy is, depending upon, there could be an underlying other possible muscle injury. So you need to investigate properly in terms of ordering, the CT scan or MRI and to look for associated muscle entrapment. Having ruled out all those possibilities, this particular patient was treated with a tapering steroid in view of, orbital inflammation. Otherwise, as far as sixth nerve is concerned, again, wait and watch policy for at least 5 to 6 months, and then take this patient for residual amount of, the strabismus. So he had a 35 prism diopter ET. As a convention, what we learn is do a R&R, but not a normal dose, more than normal dose, especially for the paralyzed muscle, and you would end up with getting, the good primary alignment post-operatively along with good motility. So that's how this particular patient. This is another interesting case, traumatic bilateral sixth nerve. Look at the AHP, gross abduction limitation, -6. It's not crossing even beyond the midline from the adducted position, more than 70-75 prism diopter of esotropia. What to do? Again, the wait and watch strategy. I waited for this particular patient to, improve over a period of time as a natural recovery. And then there is a very large residual esotropia with motility limitation. So I went ahead with, doing the SRT, bilateral medial rectus recession, along with transposition of both the superior recti to the lateral recti. So I think these are the few tips for a novice strabismus surgeon who, attempt to do this particular surgery. So you can appreciate that superior rectus cautery is very, very important, because we know that superior recti, they do have a profuse blood supply, right? So there are chances that they would bleed. So that step is very important. Then once you, isolate or separate the superior rectus, you need to quite, dissect posteriorly within the orbit so that can be easily transposed to the lateral rectus. So this is a very simple but very effective tip for the novice surgeon. Then again, the pre-placed Dacron sutures. Now you can appreciate here, I'm trying to put a pre-place. So if you are an expert, if you do more number of surgeries, you would do this, simultaneously catching both the muscles, bringing and giving a scleral bite and taking the suture properly. But you can always keep it as a pre-place so that you can do in a very precise and systematic way, as you can appreciate. So this is a 6-0 Dacron suture. You can put it there and then leave this. Then the next step is you take this superior rectus along the spiral obtuse very close to the lateral rectus, as I am taking this bite along the spiral obtuse. Once you do this, then you have transposed the superior rectus, and then you can give the 6-0 Dacron suture passing the scleral bite. So that's how the the SRT is being performed. So most of the time we end up with doing it along with medial rectus recession. So you can see post-operatively his AHP has completely gone. There was a tremendous improvement in the amount of deviation in primary gaze and motility from -6 to -3, as you can appreciate here. So definitely SRT is a very effective procedure, although it takes little more time to show its effect for at least 3 months. And this particular patient, despite that he had a diplopia, so we tried to manage by doing the prism trials and sometime by slab of prism or by giving the Fresnel's prism. So that's how you can manage this particular group of patient. So suspected traumatic sixth nerve, always look for orbital cause of motility limitation, look for orbital wall fracture, muscle entrapment, surrounding orbital hematoma. Traumatic sixth nerve, wait and watch for at least 6 months. Residual ET can be corrected with R&R. More than standard dose for resections. Extra large deviation, bilateral SRT with MR is always a good option. This is the last case, just a similar case, but a congenital onset. This is a bilateral congenital sixth nerve palsy. You can see a gross motility limitation. Old photographs, they are since birth, pretty sure. On imaging, we have seen that, the lateral rectus gone into little bit kind of, the disuse atrophy. And you can appreciate that there is a bilateral thinning of sixth nerve. And then again, I did a bilateral MR with SRT. So you see that they are in early post-operative period, they are straight. But as you see over a period of long follow-up, they start to drift because SRT is very powerful procedure. But I have seen in my experience, this outer drift is more common in patients with congenital sixth nerve palsy for obvious reason, but they do have a very good outcome. This particular patient for residual ET, I planned for probably, the advancement of medial rectus. So SRT with or without MR is a very good procedure. It gives a good outcome. Risk of exodrift in long run should be anticipated in congenital sixth nerve palsies in view of poor stereopsis and the poor peripheral vision. And SRT is a powerful procedure and gives complete effect not less than 3 months. Thank you very much.
Thank you, Dr. Vivek, for a wonderful presentation. He showed a variety of sixth nerve palsy and how the management should be there. Basically, we have to individualize every case when you are managing sixth nerve. I just have a question about injection botulinum toxin. So when we wait and watch patients, especially trauma or the ischemic variety, do you follow a rule of when we actually use Botox for the medial rectus?
Yeah, I used to use a couple of years back Botox, but I have stopped, especially in ischemic, because we know the natural recovery and there is a lot of debate whether we should use it or not. Regarding traumatic, again, we are not sure, what kind of trauma. Sometimes trauma looks subtle, but, the palsied component, the complete palsy, if it is very severe, then even if you give the Botox, it doesn't help. So in that way, I would choose, the prisms and wait and watch along with, the monoocular occlusion. Sometimes like those patients with -6, one eye involvement, sixth nerve, usually, they learn to neglect that double vision. And then we can always take a call for surgical intervention.
Thanks, Vivek. Wonderful.